Welcome to our special two-part bonus episode of our Rare D Conversations podcast series. To support Rare Disease Day 2021, we talk with Professor Gareth Evans and an amazing panel of people with lived experiences of rare cancers.
So, welcome everybody to our live event, where we are recording a special episode of our Rare D podcast, which is produced by the Whitworth Group. We're obviously using Zoom this year due to COVID restrictions. Last year we were actually at the Whitworth Art Gallery, but today we're all on Zoom, and it's brilliant to have you all here. We're going to be talking about rare inherited cancer, and this episode has been particularly made possible through NHS England and NWGMSA, and of course the generosity of our guests and all of you that have signed up to come and listen. I'm now going to hand over to Professor Bill Newman, who would like to say a few words.
Thank you so much, Nicola. Thank you, Mary Angels, and everyone for the opportunity to join you today. So I'm Bill Newman, and I'm here representing the NWGMSA. So that's the Northwest Genomic Medicine Service Alliance. So this is a new organisation that's just been set up this year. And there are 7 of them in England, in different parts of the country. So we're obviously up in the northwest and representing Manchester, Liverpool, Preston, Lancaster. So we spread from the South Lakes down to Cheshire and everything in between. And our role is a new role, but it's trying to bring genomics and the benefits of genomics to everybody who might need that. And so traditionally, genetics has been delivered by a relatively small number of doctors, genetic counsellors and nurses. And in the future, we want to make sure that more doctors and health professionals have the opportunity to use genetics for the benefit of their patients. And so we've got a programme of training and education to set up. We're trying to raise awareness by events like today, and this is the first event that the Northwest GMSA is sponsoring, so we're absolutely thrilled by that. And we have a number of projects called transformational projects that we're setting up over the next few months, which we want to see the real benefits of genetics for everybody. So we'll hopefully have a website soon. We've got a Twitter handle. If you wanted to get in touch and know more about what we're doing and about how you can be involved in the work of the GMSA, that'd be really fantastic. So I hope that today goes well. I'm sure it'll be a great conversation, and I'm looking forward to hearing it. Thanks so much.
Thank you very much, Bill. If you want to hear Bill talking about these projects, he was the first person who opened our podcast episodes, and you have all the information in our website. Thank you.
So today, we're really lucky today to have joining us Professor Gareth Evans.
Hi.
Oh, hello. Amy Hargreaves.
Hi.
Freddy Wallace.
Hello.
Fern Hamill.
Hello.
And Shaquille Bakari, who
Hello.
from work. So thank you, Shaquille, because I know it's taken a lot for you to get here as well. So thank you.
No worries. Thank you.
And also we need to say we're very lucky to have with us soon, at least sign in more than 100 participants. And we would like to remind you that the chat is open, is live during the whole conversation, and that you can write your questions and your comments and post any idea. And we hope to be able to ask our guests towards the end of the conversation some of these questions. And if not, we will put them in the website, and this will continue because we want to open this conversation further. So thank you. Nick.
Thank you. So, Gareth, I'm going to start with you. And obviously we're here today because we're talking about rare inherited cancer, and you are a professor in cancer genetics. But can you tell us what actually is rare inherited cancer?
Well, I guess, first of all, the definition of rare is supposedly less than 1 in 2,000 people. That's the usual definition. But that usually refers to known to have the condition. So, for instance, There are what we consider rare inherited cancer predisposition. One of the most well-known that people will know about is the BRCA1 gene that Angelina Jolie carries that causes a high risk of breast and ovarian cancer. And normally the two BRCA genes, as they're often called, are banded together, BRCA1 and BRCA2. And certainly in the UK, less than 1 in 2,000 people are known to carry faults in those genes. But if you actually tested everyone, it would be around 1 in 300. So that's an example of what is currently perceived to be a rare condition, which actually isn't that rare at all. And many people who actually carry faults in these genes, although they're high-risk genes, do not really have any sort of a family history that you would worry about. There are much rarer inherited cancer conditions, and some of those you don't need a gene test. So for instance, BRCA carriers don't have anything that tells you they're a BRCA carrier by looking at them. But there are other inherited conditions where there is an external appearance where you can make a diagnosis. For instance, someone with neurofibromatosis will have multiple tumors in their skin called neurofibromas and birthmarks and other features, so that you don't need a gene test to make that diagnosis, but that is a rare condition, about 1 in 2,000, that causes an inherited predisposition to cancer.
So in your role, for what reason or what stage would a patient come to see you?
Well, sometimes they're referred to make a diagnosis. So someone might have some birthmarks as a child and be sent in to make a diagnosis of neurofibromatosis, which we can do clinically, but we usually follow that up with a gene test. And then we will look at their parents. Most of these inherited conditions are inherited down the family as what we call a dominant inheritance, where all your genes come in pairs, but only one of the copy needs to be faulty for you to have that or to express that condition. There is therefore a 50-50 chance of passing it on. But there is a difference in that for about 50% of people with neurofibromatosis, for instance, and quite a lot of other conditions, they are the first in the family to be affected. So the gene fault starts with them. However, for many of the sort of more common rare conditions like BRCA, like BRCA1 and 2, like Lynch syndrome, nearly always we find it has been inherited, even if there is no history of cancer, no significant history of cancer further back in the family. But when we test the parents, we usually find that it has been inherited. So firstly, it's to make a diagnosis. So someone might be referred with a very early onset breast cancer or a bowel cancer or a womb cancer. And it's to identify, is that the inherited type, or they're referred with a strong family history. And it's making that initial diagnosis and then being able to cascade the testing around the family so that other family members can benefit from knowing if they have the condition or not, knowing if there's a risk of passing it on, but also in managing the condition. So MRI breast screening is incredibly good at picking up breast cancer early and can start at least at 30, even younger than that. Colonoscopy saves multiple lives by detecting polyps and removing them, or just detecting the bowel cancer early enough. If you detect it at a Dukes A stage, which nearly all will be on colonoscopy, then it's well over a 90% cure. So screening and management is very much part of it. So making the diagnosis and then doing the management strategies to try and pick the cancer up early or to prevent it. And aspirin, for instance, is now used. It reduces the risk of bowel cancer by 60%. So 6 out of 10 cancers are prevented in Lynch syndrome carriers if they take regular aspirin.
So just a final question on that. How do the patients get to you? So if I thought that I was kind of susceptible, what's my journey to you?
So the usual journey is via the GP. So if you have a family history of cancer, and unfortunately, because the genetic services are still relatively small, we cannot just take everyone with any family history. It has to be a strong enough family history. Many people with cancer are referred by their oncologist or surgeon because they meet the criteria to be referred, either a very young onset cancer or a strong family history of cancer. And then there are other people who, like pediatricians, see someone with coffee marks on their skin. So that would be another route into being referred.
So, Gareth, you've been telling us a lot about the way you position, or the way you work, or the way you are helping people through managing the diagnosis, through screening, and I'm just wondering where this interest in genetics came from to you. So, whether there is any, did you start with this, or you started with something else before?
So I'm a medically qualified doctor, so I went to medical school and got a degree. And in fact, I didn't know genetics existed as a specialty when I qualified. And I actually was an army cadet, so I went off and did medicine in the army as a Royal Army medical officer, and I specialized in pediatrics. And I then came across, I did 6 months at St. George's Hospital and on the neonatal unit, and came across the geneticist coming to look at some of the newborn babies. And I had always been fascinated with genetics and things that were rare. And Bob Williamson was my biochemical teacher at university, and he's a very famous geneticist, got very close to identifying the cystic fibrosis gene. And he really, I think that nidus of that interest in genetics was there. And as soon as I saw it was an opportunity, and pediatrics is the normal route into genetics to do pediatric training, I just thought this is the thing for me. And I had an interest in research, and then the rest is history. I managed to get a research job in Manchester and haven't left.
So you mentioned Bob Williamson, who was one of your teachers. Was it any other particular story of a patient or something that really took you from thinking about it to moving to genetics?
Well, I think it was he taught about genetic disease and how it was inherited, and particularly talked about cystic fibrosis and the management and how you discuss a diagnosis, and that just fascinated him. I'd always been interested in the rarer things, the more sort of I just found them more interesting, and so I used to like to sort of shock people with knowing something extremely rare, but and so that was the interest, and it's also being able to explain that, and I found I was hopefully reasonably good at explaining rare diseases and how they affected people to people who were newly diagnosed with those conditions or at risk of those conditions. So I found that fascinating. I mean, one of my earliest experiences was in a family with a really rare inherited condition caused by a gene called TP53, and she'd had a very early onset breast cancer at around 25, and her mother had breast cancer in her 20s and had developed sarcomas, which are soft tissue tumors after that, and the grandmother had died very young of cancer. And she had been constantly pushed back, saying, "Oh, well, it's not inherited, don't worry about it." And I say, "Look, I'm afraid I'm pretty certain what's going on in your family. I think it's this new gene that's been identified, the TP53. and that unfortunately you have two children that I think they're at 50% risk, and there's a realistic chance there had been another childhood cancer in this family that they could develop about a 20% chance if they carry it, they get a tumor in childhood. And I was shocked. She was overjoyed that someone had lifted the clouds away and made a diagnosis, even though that had huge implications, not just for her future risk, but for her children.
Well, it says a lot about having a sense of clarity and that somebody understands what's happened in your life. I suppose this is very interesting. And it's interesting that you say it was a shock for you. And you still remember that, Gareth.
It doesn't happen so often now. I mean, it was so hard to understand. She was overjoyed. She was absolutely overjoyed that someone had explained what had happened in her and her family for the first time. And
I'm sure we can talk a little bit about that with our guest in a minute. More guests we have, Nick. Thank you.
Exactly. I'm sure that our other guests will really relate to that, Gareth, in terms of that relief of finding a diagnosis or an explanation. So we have with us also today Amy, Frederick, Fern and Shaquille. And Amy, I might start with you. And I wondered if you could just tell us a little bit about how you've been impacted by rare inherited cancer and a little bit about your journey.
So I have von Hippel-Lindau disease. And so that's it's a disease where you get tumours in your brain, spine, kidney, pancreas and your eyes. And the kidney tumours are the ones that turn cancerous. And so for us, we found out as a family we had VHL in 2006. And it was my sister at that time had a brain tumour when she was 18. And it was she was rushed into hospital, had brain surgery, and it was our neurosurgeon who looked at us as a family and saw that my mum had a brain tumour 20 years before, and then he sent us off to Manchester to get tested for the VHL. And so it was really important that he obviously looked at us as a family, and then we all got tested at the same time. And then my mum went straight in for kidney surgery. And then we got put onto the screening process as well. So that's how it started for us.
And how did that, as a family, affect you? What kind of happened to you as a family around all of that?
I think it's a bit of a whirlwind when you first find out. You think it's a really rare thing, you know. It's such a big thing to find out that you've got all of these tumours in your body, and it's quite daunting, I think, from going from no knowledge at all about inherited diseases right through to learning about how to cope with it yourself and what has to happen then in terms of the screening and management of it and things that you have to look out for yourself. You know, one of the first things we were told by our genetic counsellor was that you have to take control of your own health. So if you're noticing things in your own body that's not quite right, you know, we have to then go to our GP or go to our consultants and explain and say we're experiencing this. Is this normal, or is there a problem there? And so I think that's how we live now. You know, we keep a close eye on our own health and monitor ourselves, and then obviously see our consultants regularly as well.
So you almost have to become acutely aware of your own body.
Yes, that's right. Yeah.
Freddy, is this something, can you relate to this a little bit, or is that kind of similar to your journey?
A little bit. So about 2 years ago, so I found out I had Lynch syndrome. So my dad had bowel cancer when he was about 28 and survived. And then my grandma had gone into hospital with some skin lesions. And the GP had decided that, you know, it might be, called it Muir-Torres syndrome, and they'd like to test her for them.
Very smart GP.
So yeah, she got tested at that time. So I rang my GP and said, kind of, you know, my dad had bowel cancer very young. I think my grandma's got this. Can I get a referral to the genetic centre in Manchester? So I went through all that, did the family tree, and then had to wait for my dad's for it to factor down, so my dad's results to come through and things like that, and then eventually got tested. I was pretty confident I had it for no reason at all. I don't know. I know it's 50-50 chance, but definitely felt like I was guaranteed to have this syndrome, and then felt a bit morbid for a bit. That obviously it's an increased risk of cancer, but I was like, oh, this means I'm guaranteed to get the cancer and all that stuff. And then I suppose then the screening started really. So I got myself on the CAP3 study, which is the aspirin clinical trial, which I've been on for 2 years now. And then started the screening process. And I don't know, speaking to people, I just kind of realised that, getting that early, I'd have had the gene defect anyway. So even if I didn't know about it, so at least if you've got the screening that you can do and you can identify things early. So kind of took it as a positive almost.
That's what I was going to ask you. Did you find knowledge was power? Did you find that knowing it was actually more empowering than not knowing it?
Yeah, after the first diagnosis, I think that's what you can the conclusion you come to.
Thank you. Shaquille, I'm going round because it's just where everyone's placed. So Shaquille, I know that you also have possibly a similar journey to Frederick in terms of, you might have to correct me on this, but in terms of bowel cancer and the kind of hereditary stage.
Yeah. So for me, it was pretty similar to Freddy's. My brother had a bowel cancer when he was about 35, going on just under 35. And we were I just went for a rudimentary appointment with the GP. And it was just an offhand comment I made that, because he knew my brother, because my brother used to live here, he's moved down to London. He's asking me how is he when he's moved down to London. So I explained, he's just come out of chemotherapy, he's better now. And he goes, what for? And I went, for bowel cancer. And he goes, oh, if your brother's had it, how old is he? And I went, well, he had it when he's 35. And he goes, oh, that could be something that you need to have a checkup on. And that was back in 2015. So literally from that, I went down and had my colonoscopies and stuff, and they found that I had polyps. And from that, originally everybody was telling me that it was, oh, it's nothing, they can be just normal, you just need to be aware of them and everything will be fine. But for me, it escalated quite quickly. After a year, I went for my second colonoscopy, and the rate of which the polyps had increased was, I was literally, you could count them on a hand first time, and then second time they were in the hundreds. And then literally, that was in April 16, about October 16, they were going, it's over 500 now. And they were thinking about doing, taking a bit of my bowel out, and they put me down for a December operation and take a segment on my bowel out. When we went down and did the pre-op checks and stuff like that, then it escalated even further, and said that no, it literally it's the entire bowel. And then by, I think it was June 2017, I had to have a full colectomy and a reconstructive surgery of my bowel.
And how old were you at this time?
I was 36 at the time.
Wow.
So literally in about a year and a half, I'd gone from not feeling anything, feeling okay, just a random conversation with a doctor, to a point where I was, every polyp they were taking out in 2016, they were saying there was a mutation in there. And if we let it, we leave it, and it would grow, and you would have 100% chance of a bowel cancer. And it wasn't just in one section, it was the entire bowel. That resulted in me having, I think it was about a 9-hour operation in 2017, left me literally from fit, healthy, able to work. I was doing like 70 hours a week, to literally I was bedridden for about 9 months, having to, learn how to walk and eat, things I should stay away from. Exercising was a problem. I had, because of the operation, you get other side effects from that. The medication gave me side effects. So, similar to what Amy is, you just sort of start learning about everything that you eat. So now I don't eat like what people eat. I would eat like carbohydrates, proteins, and things. Everything's broken down. In my diet's properly broken down. So I make sure that I'm eating all the little bits I need to get, because I can't eat raw. Even now, I'm struggling to eat raw foods. So salads and vegetables and things like that, they have to be cooked in a certain way. They have to be eaten. I also, from culturally, I'm Asian, so we like to have a lot of spices and stuff. Again, that was a big change for me. What I'm able to eat.
This has been a huge kind of very rapid change of everything, change of thinking, change of lifestyle, change of future thinking, I imagine.
Yeah, it was literally from the day it was in. I can still remember it was in last week on May. I went down and I spoke to the consultant, and literally, they talked to me about it. I'm like, okay, let's do this. And I left the appointment there, and I got home, and what he had done was he had sent me the letter via transport straight to my house before I even got home, telling me that I had an appointment the following Thursday, which was like less than 5 days for my operation. I was like gobsmacked. They were thinking it was that serious. And in my own head, I still hadn't comprehended what was going on. I was still thinking it was, not as serious as what people were saying, because you're in like a state of denial. You still think to yourself, I feel normal. I don't feel anything. And that's the thing with bowel cancer. You don't feel anything until it's pretty much right upon you.
And I guess age as well. I think lots of the time, particularly maybe in the media or the way that cancer is kind of, the narrative of cancer is often that for young people, for something like bowel cancer, when you look up, it kind of says, only need to worry about this when you're over a certain age. So I think it probably just wasn't in, as a younger person, was it possibly more of a shock or?
Yeah, I wouldn't know. It was not even anywhere near on my radar. Talking about hereditary side of it, my brother doesn't have the FAP gene mutation, so he just got bowel cancer just because he got bowel cancer. He didn't have the gene that made it, that he had multiple polyps. He just had 2 polyps, which mutated and turned cancerous. He doesn't have any other problems regarding that. So for me, again, it was thinking, but with our culture and with being, my parents coming from Pakistan, there's no history there. When we went through this with my genetics counselor, it was really difficult to figure out if any of my grandparents or anything in the past, there was a link that they could say is coming out of anywhere. My parents didn't have this problem, so there's like stories you hear, and it's really difficult to go back. There's no history there at all. Say this person had this before me, or this person before me had this problem. So it was, it's like nobody picks up on like the types of cancers you have. If you've got a cancer, you have a cancer, and that's it. And that's all that's ever told in stories. Like they had a cancer.
Yeah.
And going back in Pakistan, like pre my grandparents, there was nothing like cancer. There was just, they were ill and they died.
Yeah,
that was it.
It's really interesting, isn't it, that story of the journey down? I mean, it's slightly different, but I'm adopted, so I have no knowledge of my hereditary, kind of my history either. And I'm only noticing it now, I'm 43, when I go to, I was literally talking about yesterday, when I go to the GP or when I see a specialist, they're starting to ask now, and do you have any kind of past history of this, or do you have this in your family? And it's really difficult when you don't, or like in your situation, you knew that there was something, but it was too distant to actually trace.
There's no records at all.
No.
So nothing. You can't go back anywhere to go and ask anybody any questions. You have to ask another elderly person who, what they remember may be a bit dubious, or how they remember it is totally different to what you need as a scientific method to understand what's gone on. But like I said, at the beginning, it was very much a denial process for me. And then you go right down, mental health comes into it. It's all about me. But I've got 3 children. And then it quickly turned to the fact that if it's hereditary on me, then my children could have it. So they've all been tested. And one of my children has got it as well. But I've been through it now, so I can worked through it with him. He's 13 now, so it's really early. We can work with it, we can move forward with it, we can live with it. We understand what's going to happen, and we can work with that. So it's not like a new thing. It won't be a shock, but like that's like a good thing that's come out of it. If I didn't know anything, I turn 40, I turn 41, I get bowel cancer, and then it's really, really late for myself. But for my children, it's a really positive thing for me. It's turned out to be the fact that I know what this is now, and for my person, how going forward, it'll be something that's written down in the family. There's 5 siblings. We've all been tested. They've all been put through it with the help of my genetics counsellor, who was absolutely brilliant. She went through it step by step with us. There's been like a few people through my journey who's like kept me going. You need those people.
You do. We're going to actually, what we'll do later, Shakil, is we're going to come back and I'm going to bring Gareth into looking at the future and how, with everyone here, how diagnosis or how new technology is going to impact the future for either, the next generation, whether it be your own children or just the next generation that are coming up. So it'll be really interesting. Thank you so much for sharing that, because we will come back to that as well. I'm going to move on to Fern, and just Fern, if you could tell us, after listening to everybody else, thanks for being so patient as well. Can you tell us a little bit about your journey?
Yeah, so I am a BRCA2 carrier. So it just became apparent through family history. We kind of noticed that there was an auntie who had 2 separate breast cancers, spaced far apart enough to be classed as separate cancers. There was a very young breast cancer, and there was also an ovarian cancer. There was other cancers, but they were sort of male cancers, lung cancers and things like that. So they weren't necessarily related to BRCA, but they had happened like years before BRCA was known about. So there's kind of like question marks over whether they may have been BRCA related, but we don't actually know. So it was just from the breast and ovarian sort of history, we thought it was a good idea just to ask the GP, could this be something that we needed to investigate a little bit more? And they referred me to Manchester, to the genetics clinic. It actually took quite a long time for me to get a gene test, because there was, it was sort of like me and my dad, we didn't have cancer. So they hadn't at that time sort of tested anybody unless they had cancer and potentially carried the gene. But the people who they could have tested were either not living in this country and was very difficult for us to arrange testing, or were going through treatment themselves and it wasn't something that they wanted to do, or they were unfortunately had passed away. So they eventually did decide that they would test my dad, because he was like a bit of a common denominator to the cancers, even though he wasn't ill himself. And he tested positive for the BRCA2 gene, and so from that I was then able to get a BRCA test. So it probably took about 18 months for me to be in a position to get a test, and then I obviously had my test and was given that sort of, yes, I carry a positive BRCA2 mutation, and was quite young. I was only 24 at the time, so it was about 2013, 2014 I found out. And since then, I decided I wanted to have my children before I did any preventative surgeries. So I went down the screening route and had MRI scans. For me, I think I got a little bit unlucky. I always had something that was a little bit of a question mark and they were a bit curious about on my MRIs, and I always ended up having to go back and have biopsies. Thankfully, everything always turned out fine. But for me, I got to the point that I'd had the children I wanted, and I didn't want this like scan anxiety that people talk about hanging over me, where I was constantly having to have biopsies and MRI biopsies, which I was very thankful for, but I got to the point where I didn't want to do that anymore. So I chose then to have preventative surgeries. So about just under 2 years ago, I had a preventative double mastectomy and reconstruction surgery, and then last February I had my fallopian tubes removed, and in the future I'll have my ovaries removed to reduce my ovarian cancer risk a bit more as well. So that's my kind of journey.
No, and thank you so much for sharing it. And that's such a huge journey in terms of, and it seems quite similar in terms of taking control. So I'm imagining that the MRIs, you were saying, didn't really feel like you were in control because you were waiting to see what the results were. But has the surgery given you a little bit more of a sense of your own body? And
yeah, I actually said to Rona last week on the phone that for me, when I was 20, probably 22, 23, before you can have the test, certainly at the time that I was offered it, you had to go through so much counselling. You had to know what all your options were should you have this gene fault. And for me, at the time, being told really the best option at the moment to reduce your risk is to have a double mastectomy at 23, 24, it honestly was like the world had just fallen. Yeah. It was, I just couldn't even think about it. Now, having got my head around it and actually seeing the positive side of, I've got this whether I like it or not, so it's better that I know about it and I can do something about it. And the support that I've had from the genetics, from the breast surgeons, from the breast care nurses, from the psychologists, I can honestly say the best decision in my life has been to have a double mastectomy and reconstruction, because my risk is now less than the sort of main population of women of developing breast cancer. So taking that control back for me, you know, no one would know because I've had fantastic reconstruction from the breast surgeons. No one would know looking at me. So I can just kind of, you know, yeah, I need to be aware of things and I still need to be careful. And there's certain, you know, sort of other cancers that I just need to be a little bit more aware of. But in terms of that really horrendous breast cancer risk and actually ovarian risk, it's the best decision and knowledge that I could have, to be honest.
Thank you very much, Fern, and all of you for sharing these bits of your stories that we know is just a drop in the ocean of your story. But we hear from all of you a sense that you need to work with the doctors, you need to work with the genetic counselors, you need to be together with having control of your own health, you were saying, and you're touching even mental health. And I don't know whether you have anything you want to add in terms of the kind of things you've been doing to respond to these cancers, especially mental health wise, because you had moments, you know, you look back now, it might be somebody in the audience that they are in this moment where things are in the air and you don't know how things will develop. Is there any tip that you can tell us, or anything that it was helpful to you in terms of responding to the effects of these unknown moments and cancer? I don't know, who would like to, Amy maybe, or Freddy, say something?
Well, I think anxiety obviously comes hand in hand with finding out that you've got an illness.
Of course.
And so it's learning to deal with that at the same time. But I think for us, I think the geneticist and the counsellor was so crucial at the beginning in helping us to understand what our health condition was, and also to put us in touch with, they referred us to some amazing consultants, because we have a brain consultant, a kidney consultant, one for our eyes, and then we go to the geneticist as well. So we have a really great team around us now. But, you know, it's first of all, you know, meeting these people, learning, you know, what they will do in terms of helping you with the screening and all that, and yeah, and obviously dealing with the anxiety that comes alongside that.
So not being alone, you're saying, like, knowing you're surrounded by people that could be.
That's it. Yeah. And you learn to really trust your consultants as well, and you know what they say. You know that they've taken a personal interest in us as well, and so they've asked us about our lives and how this is impacting our life as a whole. And they also take interest in my dad as well, because you know, this obviously affects my dad, even though he doesn't have the condition. He's got his wife and 2 daughters with the condition, and so they always treat us as a family and take it as a personal thing as well, which, you know, you build relationships with these consultants over time, and yet learn to really trust their judgment. And, you know, they've all saved our lives, and so you know, you've got nothing but respect for them, and just really pleased that you've got the right people and the right team to help with that.
That's really nice to hear. Thank you very much, Amy. I don't know, Freddy, would you like to add something here? Any other a skill that you think you needed to develop, especially?
I suppose it's a bit different because I'm kind of in the screening stage.
Yeah.
I just find, when you do have the regular, colonoscopies and being on the stuff, it just gives you a bit of peace of mind, really. So, once you have one every so often and you can see that everything is all right for now, then you do just feel a bit better, a bit more positive about everything, really. So it's that peace of mind that you get from screening.
Step by step.
Yeah.
And that's the end of part 1. Thank you for listening. We'll continue our conversation and hear some questions from our live audience in part 2.